Okay, the time has arrived. Let's start. So, good day and welcome to this Smarter Health Seminar. I'm Shirley Fenton, the Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us for this seminar. I'd like to welcome our web viewers and the Ontario Telehealth Network sites. This seminar is being recorded and is being broadcast over the web. We ask that you hold your questions to the end of the seminar presentation so that we can get a microphone to you. And for our virtual viewers, please send in your questions and we will ask them for you. These seminars are hosted by the Waterloo Institute for Health Informatics Research, the Lawson Health Research Institute, and the National Institutes for Health Informatics. We are also very grateful to our seminar sponsors. We could not hold these seminars without their support. I have one announcement. We'll be resuming our Smarter Health seminars on Tuesday, September 29th. Our guest speaker will be Mr. Brance Myers, who is Director of Healthcare Business Development at Cisco Canada. Cisco, as you know, is a leading supplier of telecom and IT solutions in healthcare. I have a special announcement today. Since the Institute began in 2003, I've had the great pleasure of working with wonderful students. They have given their time, energy, ideas, and support to the Institute. They are the lifeblood of our Institute. Today we're acknowledging one of these students, Pavel Rashanov. Pavel just completed his undergraduate degree in health studies and gerontology at the University of Waterloo. He is an excellent student, enthusiastic, a hard worker, has great ideas, and he is very innovative. So he will receive our first Institute Student Volunteer Prize. So Pavel, if you could come down. Last year he was the co-winner of the first AGFA Healthcare Innovation Award contest with the prize of flying to Belgium to present their concept, an idea for software to give cardiovascular patients the way to manage their therapy from home. So, Pavel, I just want to acknowledge the work that you've done. We have a prize in here. It's listed on the back. So thank you very much. And as well, I don't think you ever got your boot camp pin. So just to go on a little bit more about Pavel. Pavel and his colleague, Naomi Chanda, presented their idea at a recent research seminar. And Dominic Covey observed that Pavel and Naomi are practically the poster kids for health informatics in this interdisciplinary field. Neither of them is in pharmacy. Neither of them is in computer science. But here they are proposing a creative, computerized way of refining drug dosages. I expect that Pavel will be another Waterloo entrepreneur. So he's off to begin his master's at McMaster this fall. We wish him all the best, and thank you. I've been doing my best all day to make sure that Pavel was here. I had him posted at the door. I had him assigned to do a duty of monitoring the webcast. So thankfully, we captured him for today. The Smarter Health Seminars this year has focused on leaders in health informatics and the e-health industry. So the schedule for today is as follows. Jim will speak for about 45 to 50 minutes, and this will be followed by a facilitated discussion. So as I mentioned, keep your questions. We'll get them at the end, and we'll get a mic to you. I'm now very pleased to introduce our speaker. Mr. Jim Schaaf is the president of Cerner Canada. Jim joined Cerner in 1996 with the responsibility to build a Canadian sales and delivery organization and to expand the business in Canada for Cerner. He has grown Cerner's business success in Canada from annual revenues of under $1 million US to more than $40 million US by 2008, with well over 250 healthcare facilities in Canada using Cerner's technologies. Cerner Canada's success is largely attributed to the deployment of effective partnerships and outsourcing strategies to facilitate the sharing of patient-centric information technologies among multiple stakeholders. In addition, Cerner was named the top corporate citizen at the Canadian Health Informatics Awards in 2006. Jim has been active in numerous aspects of the promotion and delivery of healthcare information technology in Canada since 1981, working with companies such as Digital Equipment and SciCare Canada. He has been a long-time active supporter of numerous health organizations' foundation fundraising initiatives across Canada. Please welcome Mr. Jim Schaaf.
Thank you, Shirley, and thank you all. I'm truly humbled to be asked by Dominic and by Shirley to participate in this event. We've talked about it actually for quite a while to try and make something like this happen. I will tell you now that I'm certainly not known for my public speaking abilities, so I may as well tell you before you quickly deduce that in the next 5 minutes. I have been active in the promotion of health informatics in Canada, as Shirley said, for actually more than 25 years now. And it's one of those things that when I first started, I was really fortunate in information technology to join a company that was focused on oncology treatment. And we worked a lot with the developing systems with the what used to be called Ontario Cancer Treatment and Research Foundation, OCTRF. I think they've been since renamed at least once or twice. But it was really, truly an eye-opener for me. We got to do a lot of great work with them, as with cancer treatment in other provinces, British Columbia, Nova Scotia, and others. But on the days that, I really find this health information technology in Canada to be really heavy lifting, there are some days where you just feel like the bureaucracy and everything is just going to keep you down inevitably. You'll never get to do the good things that you're really excited about doing. But I think back to this, I think his name was Dr. Ginsberg, and he was in the Kingston Cancer Treatment Center. And we were doing a lot of good work with him, but at the time, there were pretty rudimentary systems. We were automating his practice, we were registering patients, we were scheduling appointments, doing some rudimentary physician notes, that sort of thing. And I would sit in his office, and he would lament about, why can't you tell me how my colleagues up in Ottawa, or down in Windsor, or in London, are doing, how effective are they with the same treatments that I'm doing? Why can't I do this analysis and really get a better sense of best practices? That's the kind of thing that really keeps people like myself motivated and excited about this is why we do what we do. And I wish I could stand before you today and say, boy, we've got it all figured out. We haven't, but we're a lot further ahead than we were back 20 years ago. So I'm going to share with you, from my perspective, I work for a company, I represent a company called Cerner Corporation. I'm going to give you a little bit of perspective about who Cerner is, just to set the context. This is the company I've worked with for 13 years. I'll tell you a little bit about them. The observations and the opinions that I'll give you are mostly formed on my work with this company. I'll talk a little bit about what Dominic asked, or Shirley asked, was the value proposition of the HIS, the Hospital Information System. Straight off the bat, I'm not all that fussy about that acronym, HIS. That was something that was used for a period of time, a hospital information system. Most of the clinical work with IT really started within a hospital environment, largely because there was an obvious need. And also, if you're in business, one of the principal rules of business is follow the money. And that's the acute care sector they were really financing any kind of investment in information technology. However, I like to think that in the 25 years that we've been in business, we've really expanded the scope well beyond the walls of a hospital. And I'll talk a little bit about that. Some of the other points that I'll try and cover is some of the major market influences that affect HIS or HIT, health information technology, some of the other independent variables that affect really the promise and the reality. I recognize that there's been a lot of promise, and in some cases, little shortcoming on the delivery. How can we stretch the boundaries of what's traditionally been called the HIS? I'll talk a little bit about that. Major issues with state of readiness and delivering what's needed. And a few slides about innovation and where we think we're putting our investment, our hard dollars, into where we think we can best serve this market, and hopefully gain a return on doing that. So I hope that meets your needs. As I understand it, we'll keep questions for the end, and I'll do my best to answer them if you're still in the room. Cerner at a glance. Could be called a little bit of shameless promotion, but it's really to set the context is that what we're all about. If you haven't had any familiarity with Cerner as an organization, started out in small Midwestern company. 3 principals left the employ of Arthur Anderson. Those 3 individuals saw an opportunity back then. It was about 79, 1980 time frame. Mini computing was really just taking off. We could see a lot of advantages and a lot of efficiencies that we could bring to automating a laboratory environment, for example. And so that's how we started out. Those 3 principles are still with Cerner today, still very much controlling the direction of the organization. I think that's probably unprecedented in this industry, after 30 years now that they're still around and guiding our direction. And we've grown from those humble beginnings to annual revenues now of just about $1.7 billion, just under $1.7 billion US annual revenue. For large multinationals like General Electric or Siemens or others that have much broader perspective in terms of their business interests, that may not seem like a lot of money. However, for a company that's focused strictly on health information technology and nothing else, I think that places us either as number 1 worldwide in this business, conceivably. To date, we have about a little under 8,000 associates who work for Cerner. Again, of those 8,000, approximately 1,000 of those people come to Cerner with a clinical background, technologists, physicians, nurses. I'll talk a little bit about the way that we develop systems. We have very much an organic growth philosophy. We talked about this a little at lunch today. Some of the other organizations in this industry, we all have a different model as to how we approach this, right or wrong. Our belief is that we will hire the expertise, we will hire the clinicians, we will hire the technologists, and build something up from the ground up, as opposed to going out and acquiring or buying different segments of a solution and try to put it all together and offer an end-to-end solution. 2 different approaches. Another thing that we're quite well known for in this industry is our investment in research and development. There are some on Wall Street and other areas who might criticize us for that. They would like to see us pull back a little bit and just kind of, one could use the expression, milk the cow. However, there's so much work to be done to get us to the next generation of what we think we need to do and what we can do. We have a pretty fervent belief that roughly 20% of our annual revenues will go back into research and development. And this is true R&D, this is building systems, and this is not, as I said, an acquisition philosophy. So we have almost 2,000 members of our IP, our intellectual property, our engineering organization who do nothing but building systems for health information. A little bit about market acceptance. So with that kind of annual revenue, that kind of 30 years in the business, where does that put us? Pretty large acceptance, obviously, to generate that kind of revenue in the marketplace. We have a platform that we refer to as Cerner Millennium, which is really a collection of all of the various applications that we supply. Of those Cerner Millennium applications, there are more than 8,300 of them live today in various settings around the world. As you might expect, and you all probably study these, Gartner and Class and others in terms of assessing what are the strengths of suppliers like Cerner and others in the industry. And we're pretty proud of some of the accolades we get from Gartner and others, that we are seen as a leader out there and continually pushing the boundaries of where we need to take the effectiveness of our technologies. And by virtue of some of the work, as I mentioned, we started out in a small lab in a hospital in Midwestern United States. Today, by the bottom point here, we're working in some very, very large jurisdictions in the UK and elsewhere, where one of our largest implementations to date has something like 6,500 concurrent users. That's a large system. And in keeping with our philosophy of extending boundaries and so on, expanding our global reach is one of the pillars of our go-forward strategies in terms of extending our business. One thing to note is that this platform that we refer to as Cerner Millennium was built. I was talking to Shirley and some others over lunch about how in the mid-90s we had really come a long way in terms of being able to automate laboratories or radiology departments or various departments within a hospital, and we got really good at it. We thought we're considered best of breed in a number of areas. But really, we had created a number of siloed solutions, and they didn't readily talk to one another. They didn't really take advantage of relational database capabilities at that time or distributed computing. So we made a hard decision to say, you know what, we can do this a lot better, and in order to do so, we have to kind of start again. We have to go back. So get the best and brightest into a room, and how would you go about doing it? And we started again, and this was about 95, 96, right at the time when I was first joining Cerner, that we did it. And we said, well, let's change our focus a little bit in terms of just focusing on the provider or the technologist, make sure we handle their workflow. How can we get a real cross-continuum view, and how can we really develop a really robust architecture that really is suited for environments like Canadian environments or other publicly funded healthcare environments, unlike the U.S., where our governance structure is such that we really have an end-to-end responsibility for the health of our citizens. So we created this brand new architecture. We use Oracle at the back end and HPs and IBMs and others technologies to deliver our solutions. And it's really designed with a patient focus. In fact, we don't even like to use the term patient focused because it's really person focused. The whole idea is that we start out with a clinical data repository underneath all of this, and there should be one person, one record is the philosophy. And if in fact we're soliciting information from other systems, foreign system interfaces we call them, that's fine. We have obviously great interface capabilities that we can bring information in from other systems, but there's still only one lab result or one test for that particular procedure that's on record. So we don't like to have duplication anywhere. So we did it, and in 95, 96, our stock took a big hit because we were going to invest a significant amount of money to start again. And I'm pleased that it was the right decision. It's one of those sentinel points in our history, I guess, where our leadership really made some hard decisions to say, rather than carry on and just proliferate what we've done, let's start again, let's invest big time, because we think that's where the industry really needs to go. I mentioned our global market presence. We're in 18 countries today. Canada was really the first foray, outside of the United States. We look upon our expansion in the global market space as in business, as you know, if you stop or you slow down, you're dead. So you just have to keep moving. You have to keep extending your capabilities, extend your reach, and extending our reach is a big part of our philosophy. So that's why we spend a lot of time in different parts of the world. The comment here is about we have significant market share in the UK. You've probably even studied some of the work that's been going on there. We're doing 2 very, very large implementations in the City of London and in the Southwest. Cerner was also responsible for the National Health System Choose and Book e-referral system that you may have heard about or you may have studied about, which is really an electronic referral system between GPs and specialists up and down all of the NHS. That's intellectual property capital that Cerner developed and implemented. In Canada, I'm really proud of the work that we've done on the West Coast. For example, Vancouver Island Health Authority. We started out automating one hospital, I think it was the Royal Jubilee in Victoria, which extended over time to the point where now they've turned off all of these other various silos of systems and data sources up and down the island to a single instance of a Cerner Millennium platform. So all of the work that goes on in the 20-some-odd hospitals up and down Vancouver Island all interact with this single implementation. And I'm a strong proponent of, especially in Canada, leveraging that even further. These investments are big, they're audacious, they're expensive. They're not for the faint of heart, but once they're made, they really have applicability outside, as I said, the four walls of a hospital. And I think they should be shared with others, with community caregivers, with general practitioners and others. So there's a lot of work that we're working on with VHA, with London Health Sciences, Prince Edward Island, a number of other areas across the country. This is just every year we have a users group that gets together, all of our Canadian clients, and once a year we'll pick a spot. This year was in Niagara Falls, and I usually spend an hour with them at the kickoff and just kind of do a scan, a cross-country scan of how are we doing together, and just facilitate, here's the work that's going on in other jurisdictions, and be a facilitator for each of those organizations to interact with one another and learn about best practices and share experiences. And the great thing about, publicly funded healthcare system like ours is, we can go in and there's nothing greater than Prince Edward Island is going live, let's say, with CPOE or something like that, and someone from Prince George, they send over a team of people to help them. That's the kind of collaboration that you can get in a system like ours, unlike a privatized or competitive system that you see south of the border. You don't have that same level of collaboration. As I mentioned, I really don't like that acronym HIS because it just sort of belies what the architecture is really all about. But it is where we started, and kind of, in the middle there, we started with departmental information systems and built our capabilities up from there, from the center up to the left. So we went from departmental to clinical information systems, much broader, facilitating an electronic medical record. Then we went enterprise-wide to evidence-based medicine, to really a whole health economy across a large geography or jurisdiction. And then we kept that same architecture going in the other direction and taking it down to really connecting the bedside, personal health records, and really even getting down to the genome mapping expertise. So what are some of the major market influences that we've seen and that we experience? There are plenty of them, obviously. Healthcare is extremely complex, extremely data-rich, extremely information-dependent. But compared to other industries, woefully underfunded. There's been a significant amount of press and attention given to the affordability of the system that we have. In Canada, I don't know what it is today, surely 11-12% of our gross domestic product, and continually outpacing other expenditures to the point where there's an affordability issue looming in most countries that we cannot afford the way that is going. And for one thing, technology is seen as an enabler to help remove some of those efficiencies and get the cost back under control. There were a couple of instances here that you also may have been, or you may already be aware of. The Institute of Medicine, it's issued a report back, I think it was 98, 99 timeframe, to err is human, and really introduced to the agenda of health information technology the concept of better patient safety. The press was such that 98,000 people, and this was a U.S. study, 98,000 people or so were being harmed every year with preventable adverse drug events. And when you draw the equivalent of put that into context, that was like a 747 crashing every day. Why are we tolerant of that when there are technologies able to improve upon that? We certainly wouldn't be tolerant of Boeing crashing 747 every day with that many people involved. So it did create a little bit of an inertia in the system, and I think it wasn't too long after that the CPSI, the Canadian Patient Safety Institute, was formed, and a number of folks are obviously focused on introducing new technologies and others to improve upon that. Take that complexity down from a systemic level, and this gets more into the hospital environment. And this pictorial came out of a Life magazine story that was done a number of years ago. Don't know whether you've seen it or not, but they were really highlighting the complexity of the amount of information required and the number of people who were involved in the care for this particular patient with chronic heart disease. There were well over 100 people who needed to interact with that patient at one level or another, needed to exchange information with others, and we kind of superimposed that schematic behind that at the time. we were all living very much in a best-of-breed world, so there were numerous silos of information and systems out there and organizations. And this is not something there was one of our clients gave us that schematic. That's how they were trying to handle all the interfaces between the various systems to be able to accommodate that information flow. This is the kind of thing that drives us to the more integrated approach and said that that's really not workable at a certain point. And to break it down even further, down into the ICU and other levels, I mean, how do caregivers, I mean, obviously people do a great job of being able to deal with this kind of complexity on a day in and day out basis, but there is a better way to be able to aggregate, to pull that information off of those monitors, actually link it straight into the electronic health record and make it available and reduce some of that complexity. There's another dimension, and we talk about market forces and things that are driving this market, and that's the time it takes to get best practices or clinical research back into the actual caregiving setting, and in some cases can be as much as 17 years, just because of the processes defined here. And I forget that this is a I'd never been there, but I love the picture. Oaxaca, I think it's pronounced in Mexico. It's a petrified waterfall view, and it looks like it takes forever for anything to get from top to bottom. However, and that's the whole idea. To look at it a different way, there's so much information coming out, regardless of the pace at which it comes out, for a general practitioner to keep up on, or any other clinician, that this analogy is simply meant to, at a certain point, it's impossible to keep up to date on all of the new information coming out. And this is just meant to show you the sipping from a fire hose. Some of the other major forces that are all kind of coming together, congruence of these 4 different areas all at one time: demographics, consumer expectation, the advancements within science, and the advancements within information technology. We live in an interesting age. I guess we could always say that. But as all of these pressures come together, it really has a significant impact on our market. If you don't mind, I'm going to take my jacket off. It's a little warm in here. I think most of you have yours off. Demographics, I don't need to spend a whole lot of time on that, certainly. Thanks, Shirley. But the baby boomers are coming. I'm sad to say that I'm actually one of them. I haven't had to use the system much yet, but I want it to be ready for when I do need it. So there's a great deal of information published by CIHI, by CIHI every year, and we track obviously the growing expectation of considerable expenses as we move through this bubble. And as you know, we consume the greatest healthcare resources and costs in the last several years, in some cases several hours of our lives. And we have this bubble coming through the system referred to as baby boomers that we have yet to realize the full impact of. Consumers' expectations. We had a great conversation over lunch about, there was once a time when, you or I would walk into a physician's office with the utmost respect, and we still have the utmost respect. But there is a waning of the undying reverence that we gave to that physician, that we didn't question anything. Whatever was he or she said, we just took it all and just kind of okay, and then left the office and did whatever we were told. But with the proliferation of the internet and the great deal of information available to folks now, the physician is a lot more challenged in terms of expectations of consumers. Consumer really wants to be much more active in terms of their care, bringing lots of great ideas and challenging the physician on various aspects of treatment and so on. So we're seeing a lot of that start to come to the fore. And of course, there's significant advancements in science that continue to stretch the HIS or whatever you want to call it. The expectation is that after the completion of the Human Genome Project, I think it was in '99 or 2000, that we're expecting that the prescriptions and medicine in general will get to be a lot more personalized. And we need, as a technology provider, to be able to make that part of the electronic health record. Information technology, it's firmly believed that IT will really continue to advance significantly. I mean, we're already, I'm sure all of you are pretty much the same as me. I mean, this notion of being connected anytime, anywhere this thing will go off at midnight and people will expect you to answer it. So I mean, we're already quite far down that road, and I think that the basic technologies, the network, CPU, et cetera, will all continue to advance in capabilities. One of the things we were talking about earlier was how cheap storage is these days. I mean, most of our electronic or our clinical health records, we don't really archive anymore. There's no real need to keep it all real time. Devices will really be ubiquitous, smart, to be more chips embedded, nanotechnology becoming much more commonplace. Application software will be extremely layered, with the whole cloud concept and service-oriented architecture. We'll all be expected to be able to provide those types of applications and those kinds of information handoffs. And overall, the architecture will still be, we think, complex and expensive. It is today, difficult to build and difficult to manage, but that's part of what we need to evolve through. Could spend a little bit of time on historical perspective. Every once in a while I do this just to look back and say, well, how far have we come? I mean, we've talked a little bit about what's on the horizon and the types of things we need to be prepared for. There's been a long-standing belief especially in the acute care sector and the HIS sector, we need to digitize as much as is possible. Get rid of the paper, get rid of the pen, get rid of the scanned images. And then we can really put the emphasis back on the clinician, so that when they're making the decisions, and for years, several years now, we've been promoting this idea of CPOE, clinician or provider, computerized provider order entry. The thought being that if we can get to the physician at the time of placing an order, we'd really like to be able to get as much information to them as is relevant before we have those 98,000 adverse drug events or other problems. We can't really convince that clinician to really get to that point until we can give them as much information electronically as we possibly can. We're very close. Now we Cerner have, I think, well over, I can't remember the number, but it's well over 100, maybe a couple hundred live sites with CPOE. We talked a little bit about a physician in their office with the terminal and how intrusive it might be in that encounter. But even in the mid-90s, 95, 96, I remember sitting in Mayo Clinic in Jacksonville, Florida, and we had already worked with them. I think they were our first paperless clinic. And I was actually invited into the room while the physician interacted with the patient, and we sat there. And he made it very clear that the computer was not between them, but rather beside them. And in fact, throughout the whole encounter, they were both looking at the screen and talking about various aspects of the diagnosis and the care. And I thought, we're really getting there. We're really making progress. Just to close off on Cerner, and we developed this architecture called Millennium. We put a clinical data repository underneath it. We put a lot of different applications on top of that repository, all of them interacting with one database. As a result, today we can go into a hospital and offer up a single departmental solution. For example, we can automate your lab, general lab, microbiology, anatomic pathology, whatever. If that's all you want from us, great. Happy to do it. We do that actually for the city of Calgary. They're all sharing a single Cerner lab system. Ottawa is pretty much the same thing. Halifax, Victoria. Then there are others who have a much broader view and say, well, we like your vision for an integrated approach, and we'd like to put all of that infrastructure in place so that we can have our lab, radiology, pharmacy, and meds, everything all on one database. And there are tremendous number of clinical and financial incentives to do that. But we recognize that we can't be everything to everybody, so we try to serve both markets. So there are those groundswell types of synergies out there from science, from information technology, et cetera. But then there's some of these other independent variables that are out there that kind of impact how are we doing and what's slowing us down, or what are we focused on to speed us up. Forgive me, this is just a map that I used for my U.S. colleagues whenever I have meetings at our headquarters in Kansas City. I sometimes have to remind them where Canada is, just south of the border, or north. There's been a lot of changes in our healthcare sector. When I first started, we didn't really, I don't think any province had really settled on this concept of a health region or a health authority. So from a sales and marketing of information technology and that sort of thing, we were out there, you had people darkening the skies from coast to coast, trying to cover I don't know, how many did we have, 1,200 or more individual hospitals, everybody doing their own thing. Just in that brief period of time, in that 13 years that I've been here, pretty much every province now has aggregated that level of care to health regions or health authorities. And so you no longer deal with a single entity, a hospital, and that's why I struggle with an NHIS. We don't really deal with a single hospital anymore. It's much more complex, and we have 83, I did a count, I think 83 health regions or health authorities now. So if somebody wants a lab system, I don't talk to the Royal Jubilee Hospital in Victoria, for example. I talk to the health authority. And chances are it's not going to be just for one, but it's going to be a much broader implication. And unfortunately, when you're driven by sales cycles, and as a publicly traded company, you live in 90-day windows. 90 days is like a year, so there's 4 years in one. It really elongates the sales cycle. It's in some cases, in publicly funded systems like ours, it can take multiple years to get to the point where you actually conclude an agreement to say, okay, let's go and do this level of automation and let's proceed. But we have core values, and the Canada Health Act principles. There's things that really guide the delivery of care across the country. The whole publicly administrated, comprehensive, universal, etc., are all part and parcel of what we all have to serve. By comparison, and again, sometimes when I'm south of the border, I will draw analogies like we have 32, 33 million people in Canada at most. We're about the size of California. Interesting context. Some of the challenges and stresses that we face that are particularly unique to Canada, or maybe not, they are certainly prevalent here in Canada. And I mentioned the whole baby boomer bulge coming through the system, and the greater demand we're putting on healthcare resources. There is a shortage of general practitioners booming. We've talked, and I haven't seen as much evidence of this yet as the rhetoric has indicated, but there's been ever since restructuring really took hold, from my perspective, at least in Ontario, and a number of the Sinclair and other commissions that were struck. How do we change? How do we get better? How do we reorganize ourselves? And one of the areas was this fundamental belief that we were going to move as much as possible out of the hospital setting, out of the acute care setting, and put it out into the community. I still think that's a vision. I still think that's important, and I think it will happen, especially by virtue of all of the other pressures on the system. But I'm not quite seeing it yet, and I'm not quite seeing the investments. And again, if you take the philosophy of follow the money, not a whole lot of investments out there yet. I mean, community cares, CCACs and others doing great work and that sort of thing, but I'm not seeing them get the investment they need for IT and others to the level that we would all like to see. But I think it is coming. So some of the major issues associated specifically with HIS, and are we making progress? I'm sure that most of you as students will have seen this EMR adoption model, and we have these 7 levels, actually up to 11 levels of automation, and how well are we doing as an industry? This data is a little bit outdated, unfortunately. I apologize for that. It's probably at least a year old, but it's hard to take heart in some of these numbers. If you start at the bottom, how many organizations are still down here in terms of having all 3 ancillaries are not yet installed, and that's laboratory, radiology, and pharmacy. Roughly 18% have yet to automate that level. Clinical data repository, how many have a clinical data repository? Excuse me, it's 21.8%. Clinical data repository with a controlled medical vocabulary so that you're able to achieve the one person, one health record thought, clinical decision support, et cetera. 42, not even half of the organizations have automated to that level. And really getting up into clinical documentation where nurses are actually documenting their charting online. And PACS and others, 14.2%. So we have a long way to go. I like to think at sometimes that we have made a lot more progress than that, and there's lots of reasons why we haven't. Not the least of which is funding and other things. One of the things that Cerner has been working on a lot, and this is probably not interjected in the right place, but getting away from, I would say that we've gone through several iterations of design. And we didn't necessarily get it right the first time, especially when we went into a physician's office and some other settings. Maybe we were too much engineering focus and not enough clinical focus when we did that work. So I would admit it probably took us in some cases a couple of iterations to get it right, to get adoption, get usability. And one of the things we're working on now is really a lot of work to make one of the hardest things to represent real time is really the flow sheet in intensive care. If you've ever seen one, they're massive, they're complex. There's a lot of information that you need to get out there to those clinicians, and it's got to be real time. It's got to be relevant to that patient and that caregiver. So we have really gone through several iterations of that to the point now where we've got this gadget approach whereby we can bring up all of this information coming from a Cerner database or someone else's database and bring it up real time, and actually allow the organization to construct these views to the way that they want. This is really a half-a-day discussion unto itself, but this is just one of the levels of advancements that we're really working on. I guess I'm trying to explain what are some of the challenges. I was asked to speak to a little bit about my observations about where are the shortcomings, why haven't we gotten as far as we would like to. In some cases, the implementation track record in some of these big projects is not stellar. It's not good. Taken a lot longer than anyone would have hoped, a lot more costly. I like to think we've made a lot of advancements. I like to think we've done a lot of good. And one of the things that I think Dominic had sent me was a STED report talking about the chasm between the promises and reality and why is it taking so long. And I think he referred to two levels of changes. One was evolutionary and the other was more profound and radical, he called it. Most of the changes that I've seen are much more evolutionary. We build on our experiences. We take, we learn lessons from the last implementation or the last level of last release of technology and that sort of thing. But from time to time, there are some radical or revolutionary changes that we are, in fact, part of. I'd like to be able to talk about those. So we've been challenged as an organization, just like any other in this business, to really offer up predictable outcomes. And we cannot go into these multi-year implementation, let's say for an electronic health record or a CPOE initiative that from the outset is predicted to take 2 years, let's say. We've got to get better at it. We've got to be able to fix fee it, fix scope it, and deliver it in much shorter time frame and certainly on time, on budget. So a lot of learnings have come out of that. Given the fact that we've done so many of these, we put an extraordinary amount of effort into being able to offer up some really predictable services. We've pulled a lot of it. I used to send people out to go and do some of these implementations that were, let's say, multi-hospital, multi-application, do all of their ADT registration, all of their ancillary departments, all of their clinical documentation, that sort of thing. I would send a team out. And the unfortunate thing sometimes about our technology is it's designed to serve 18 different countries. All these different settings, number of venues of healthcare. How do you do that for everyone with one release of software? So when we install it in Victoria, someone in Abu Dhabi may be installing the same software, and there better be enough triggers and so on in there to be able to serve us all. That's challenging, but it also has its rewards. So as part of that whole exercise, it's forced us to go back and say, let's really stop this notion of building from the ground up every time you do an implementation. Take your experiences from the last 80% or whatever that you've done. Start from there as a foundation, and then do the tweaking and the changes and so on with the remaining 20%. And that's really served us well and cut our implementation times in half and that sort of thing. We've taken a lot of the work back in-house, almost like a factory setup, whereby we have a solution center where we say, well, you're only going to build this system once. With the investment in these types of technologies, this is not for the faint of heart. You don't do this every 5 years anymore. It should be a minimum of 10 years commitment to this, to this system. And we like to think when we have a relationship with a client, it's a lifetime relationship. So do you need, when we're building this system, do you really need to know all of the intricate details of how we built it up? Or should we do that build for you because we have people who do that day in and day out? So we've taken a lot of that work back in-house, and we will bring clients in and say, here's how it looks, we'll prototype it for you, what are some of the changes that we need to tweak for your organization, and then take it back out. Much simpler approach. We've invested a lot in process modeling, simulation, comparative analysis, things like that, to try and make sure that we've learned lessons from others that we've done. Making sure that we embed executable knowledge from our own sources or from others, order sets and things like that, from Zincs or Clinic Guide and others. How do we embed that into the workflow of our ordering system and others? One of the big things from a technology perspective is improving availability. When you get into some of these very large implementations, historically, organizations did not spend a lot of time and effort, largely because of budget restrictions, in making sure that there was really good and robust disaster recovery or failover capabilities in the technology. And by and large, healthcare organizations are not incented to have big, database or data centers and big investments in technology like that. And yet, the more you get to CPOE and others where you have no paper to fall back on, you're completely reliant upon the technology, you really cannot afford to have downtime. And if you haven't invested in that, you better start thinking about it. And some of our biggest clients were very quick to come back to us and say, why don't you take it over? Why don't you bring it in-house? You've got the expertise. You built these systems. Why don't you run it for us? So in large part, that's what we've done. We bought a data center from Sprint in Kansas City, Missouri, started hosting a lot of our large clients in the United States. We put it in that data center, and we manage that system for them. So we offer it to them as a service. I've tried to bring that to Canada. Patriot Act complications prohibit that. We can't have our data, although every province doesn't have legislation prohibiting that. Nonetheless, I haven't found any clients in Canada who will accept having clinical information or patient information exist outside the country. In a lot of cases, not even outside the province. So we're working hard on a hybrid of this model where I still believe it's the right thing. I still believe that most healthcare organizations do not have the wherewithal, should not necessarily need the wherewithal to be managing these systems. Leave it to us. Let us do it. And we've been working with Prince Edward Island as our first client in Canada. We'll buy the equipment, we'll put it in a data center, we'll manage it for you because we manage all sorts of other systems, and that's just a service to you. And it's not up and running yet, but it will be later this year, and I think it's a good model for others across the country. Innovation, I'll just take a few minutes and spin through this. As I said, we've really gained a known for in terms of health information technology, constantly trying to grow the business. We've picked 4 venues. If you look at what we've done historically in the middle of that graph, our go-forward investments, first of all, we'll continue to enhance that. I mentioned that we'll be doing a lot more focus on programmatic technology support, especially in the areas of oncology, women's health for the moment, and then we'll expand beyond that. But we will really be providing more emphasis on global expansion. Pharma and data, we'll be supporting a lot of that. We've actually gotten in on the bottom of the slide, there's an indication there, we've actually gotten into, in a fairly major way, branding our own technology. We're on our 2nd generation of meds dispensing devices. We think that there are a lot of good reasons for that because we will connect it directly with the electronic health record. We have all of the information from the health record communicating directly to that dispensing unit, and it's proving to be quite effective. The top one is not so much applicable here in Canada, but in the U.S., our cobblers are wearing our children are wearing our own cobbler shoes. We're actually automating a number of clinics and have our own clinicians on staff. So of the 8,000 associates that we have, more than half of them are on our world headquarters campus in Kansas City, and we have our own GP set up there. And we've been invited in by some very large multinational corporations to do the same for them. So that's really quite interesting. What do we see as some of the directions going forward? Hospitals will really become a fabric of of healthcare rather than the center of healthcare. Still think that expansion outside of the four walls of the acute care setting will in fact change. Major chronic diseases or conditions will have been much more systematized, starting with detection, early intervention, continuous monitoring and treatment, that sort of thing. As I said, the pronounced trend is really outside of the hospital, and I think that will continue. Physicians' offices will become a node on the network. Strong proponents of physicians' offices sharing the infrastructure that we've already invested in the other settings. By and large, and we're already working with a number of clients like VHA and Prince Edward Island and some others to put this to the test. Given that at the end of the day they're all seeing the same patients, it's only appropriate, I think, that they'd all be sharing the same information. Medical education will be redesigned, obviously much more embedded into the system. The whole fire hose, sipping from the fire hose thought. We need a way to be able to bring that knowledge, to bring those best practices to the desktop at the point when it's appropriate. Major chronic conditions will evolve as systems of care, much more real-time or near real-time diagnostic data, therapeutic data being available, globalization. One of the things a company like ours, where we're working in 18 different countries today, we can actually bring a level of best practices from outside our own jurisdictions and bring them back into our own country. And I think that we'll see a lot more of that, and especially in today's world where we're also concerned about the next pandemic and so on. The whole device fragmentation, I mentioned we put a lot of emphasis, a lot of our R&D dollars into how do we clean that up, how do we make that technology much more connected, if you will. We're working with a lot of big organizations, Hill-Rom, for example, with beds and others being invited in to help automate new wings of hospitals and that sort of thing as we go. I'm going to skip that. It's much more U.S. relevant, and the whole cloud technology. One of the things that investors, when they turn to us and ask us where we're going in the next 5 to 10 years, they want to know, and we really struggle with, where are you going to, well, an HIS company? Do you want to call us an HIS company, or maybe an HIT, Health Information Technology company? Will we be an information utility, a data company, a medical technology company, condition management? Risk management, starting to foray into that whole area. Public health network. We're going to be contributors to all of those, and in fact, today, to some extent, we already are. So I struggle with the acronym Hospital Information System Supplier. It's really not what we are anymore. Some closing thoughts on the Canadian HIS market. I think I'll skip that, Shirley, in the interest of time. It really is a reflection of all the things we talked about in a more global context, but the Canadian market is really not that much different. I do like to lament about the lack of sufficient funding in IT and healthcare in Canada, but that's my own cross to bear. Yeah, I've already covered all of this, the whole consolidation, the whole health authority or health region kind of focus on HIT as opposed to individual interests anymore. Infoway's done a lot of great things. I love the fact that Canada Health Infoway brought a renewed focus to this market. The segment of the market in which I'm more involved in, we've done some things with Infoway support. We've helped with the PACS initiative down in Southwest Ontario. We've done some good work in Prince Edward Island, but by and large, the Infoway dollars have been focused on a different level of infrastructure, I would call it, as opposed to pure investment into hospitals or GPs. And I know that the next go round, if that 500,000 or 500 million ever gets approved, really that some of that investment will go back into an area that's more germane to where we're working today. There are others in the industry. As I mentioned, lots of great companies out there doing lots of good things. And I said to Shirley and to Dominic, I would forgo talking about the value statements of any of those. I'll leave it to you and to other industry pundits to talk about what are the strengths and weaknesses of each of them. But by and large, these are the ones that I see on a daily basis and are more active in a global setting. And I'm going to leave it at that, if that's okay with you, and open it up for any questions.
All right. Well, thank you very much. I invite the audience now to ask their questions. We've got 2 mics that will circulate around the room. So if you have a question, please raise your hand and we'll get a mic to you. And if there's any questions from the web, please send them in. So anyone have a question right off the bat here? One at the back.
You mentioned that Alberta has collapsed its regional health authorities into one, and Cerner's involved, at least in the southern part of the province. What do you see occurring as one executive director or CEO of a health region that covers the whole province means in terms of integration of things like home care services, the hospital services, the public health component, long-term care, all of these elements having degrees of interoperability that had never been possible before because of the political boundaries between and amongst the various institutions, which now have essentially disappeared?
Yeah, we are in fact active in Alberta and have been for quite a while. We've automated the full lab information system across the city of Calgary and actually expanded it across the southern part of the province, as we have with radiology information systems, and in the process of actually rolling out a scheduling system for the southern part of Alberta. And we have some presence up in the north as well, in Edmonton, where we've automated the U of A hospital with a pharmacy information system and some others. So we have been active there for quite a while, and we watch it with great interest. We're very active with them at the moment. I think that it's audacious what they've taken on to be able to do that. I wish them well, and I'd love to be a part of it. I don't think that there will be a grand plan or a single centralized system to do it all. I think they will break it up into reasonable views or perspectives, and that might, because there are already legacy investments to consider as well. And as I mentioned, these investments, you no longer put those systems in for 5 years. It's just not practical. I mean, in some cases it takes 5 years to really start to see the full benefit of them. So I think some of those legacy systems will survive, at least for quite a while. And I expect that, they may try to automate lab throughout the province, for example. Gain some there's some business case to be able to do that. There's some clinical improvements that can come out of that, I think. Maybe the same thing with radiology. Maybe patient care will be siloed. Maybe GP market, I don't know. But certainly trying to be a part of that discussion and the solution of that whole outcome.
Question here?
But, Prince Edward Island is the one instance, by the way. I'm very proud of the fact that they have a single CIS. They're the only one in the province, in the country, albeit 138,000 people, but nonetheless, it's a whole province. It may well be. And really, for us, it's a great microcosm of everything we do because it's manageable. It's a whole province. The full governance structure, end to end, is all there. And so we're very active with the people there and really proud of the work that we're doing so far. We have a long way to go, but
I'm just curious that what kind of technology or knowledge are involved in HRS. I guess database is definitely important stuff. So what about others? Maybe networking, or I don't know, something.
As I mentioned, when we went back and redesigned our architecture to take advantage of relational databases, we settled on Oracle. Obviously, when we get into some of the very, very, very large implementations that we have, we need something as robust and as industrial as the Oracle database. Back-end data center, I mean, we employ pretty much standard technology from HP or IBM. We offer both platforms. We try to be as agnostic in a number of areas as we can, so that our clients, our users, have as much choice as is possible. We offer up, thick client, thin client. We use Citrix and other venues. We use the web wherever applicable. Constantly rolling out, various improvements upon that technology.
Just a question over here on this side.
Hi.
Is this working?
It's on.
I think so.
Okay, perfect. I'm wondering about the data that's being housed in there and whether it can be exchanged with other, say perhaps a family physician practice that has a piece of software, but it isn't necessarily a Cerner piece of software. Can they utilize the data being used at another location, or for even research purposes?
Right. Great question. And of course they can. We don't have an implementation as much as we try. I mean, we try to do as much as we can because we think there's a lot of value in the integration, not just clinical value, but financial value. But we recognize that we can't do it all. Never will do it all. So one of the, a big component of our engineering group is we have what we call a foreign system interface group, who do nothing but, and I don't know, the last time I counted, there were something like 200 people in that organization, who do nothing but figure out how to handle transactions, how to interface with other system suppliers out there. And HL7 is generally the accepted, standard today. HL7 version 2.X. We're constantly being pressured by Infoway and others to get ourselves up to HL7 version 3. And my response is absolutely, as soon as it's required and clients want it and need it, we'll be there. We're already working on it in the UK. And the same thing applies. So we do a lot of that. I mean, we have interface engines that we work with. We have our own. We have others. And we also do a lot of work in terms of medical device interfaces, as you might expect with all the work we do in the laboratories and so on. So that's a big part of our capabilities as well, making sure that we can interact with all of those devices. Okay.
Is a question from the web?
I have several questions from the web for you. The Canadian revenue is 2.5% of total 1.7 billion. How much influence does it have on the product direction, given our publicly funded model, although similar to the European model?
That is a great question. As I mentioned, we are the size of California. However, I also mentioned that it's extremely important, it's strategic to Cerner that we expand our reach outside of the U.S. Canada was the first example, the first foray outside of the U.S. And I often meet with my colleagues from outside of the United States, so my counterpart in Australia, in the Middle East, in the UK, in France, Spain, and other jurisdictions. And, we all quickly came to the realization we are very, very similar in our healthcare systems. And one could argue that even though a lot of the real innovation has come out of the United States, which I'm really thankful for, they are the anomaly, because the rest of us have very similar healthcare systems. And if we're truly going to be successful in global markets, figure it out in Canada and you can figure it out anywhere. So We have influence. I can't tell you how much influence we have, but generally speaking, we're seen as a good test bed and a good influence or a good indicator of what we need to do globally. So we try to bring special requests, special direction to our engineers and say, you really need to be thinking about this because this is where not just Canada, but other markets are going. And that works two ways. I personally would like to see that choose and book system that's active in the UK in a different form, but the way that it's structured to be able to facilitate better management of the resources that are available, better linkages between primary care and specialty care. We've done it for all of the NHS. It may not be perfect for Canada, but we could certainly benefit from what we've done there, bring that system home to Canada and put it in, in a number of provinces across this country. So there's a lot of benefit both ways to that. I hope that's answered the question.
Thank you. From Dominic.
Uh-oh. I don't know why I'm nervous, but...
What are the potential areas that might be integrated, merged, significantly reorganized, or replaced within today's hospital? In other words, what are the opportunities for significant innovation that can be realized using computer-based systems? Also, what are Cerner's contributions to such?
Yeah, I thought it would be a tough question. We've done a lot of automation over 30 years of experience within hospitals and outside of hospitals. I think that the thing that excites me the most right now is taking it to a different level in terms of a programmatic approach. We can automate processes, we can make things more efficient, we can share information better. But I think when we really start to get into supporting things like women's health and oncology, we can get a lot better. We can get a lot better at embedding best practices and better outcomes can be achieved that way, I think. So that's really going to be a focus going forward.
I guess I'm curious, before you go on to your third question there, I'm struggling with this concept, or I guess what your statement, that it's really a 10-year investment. I think that's the number of years you said. But how do we get how do we get what I would call disruptive technologies in there if it's a 10-year investment? How do you balance those two things?
I mean, that's a great question. Where's the leverage? I like to think that we're innovative enough and we're challenged enough day in and day out to be innovative. And any organization that spends 20% on their revenues had better be doing something innovative,
that it's just embedded into the mechanisms that you're doing already.
Absolutely. But how do you how does someone as a client make sure that we're focusing those energies and those dollars in the right areas? Through active forums. I mean, any client that I can think of in Canada is not shy to tell me where they think we should be investing those dollars, where we should be disruptive, where we should be innovative. I like to think that we're listening to them through the various forums that they have.
And then I guess the push from the other side is how do you re-engineer that and get acceptance by the communities when they're in a very, very busy environment. So it must be extremely difficult to manage the innovation, the stability, the people that may not want to change, and so on and so forth.
Absolutely. And that's why I say, I picked 10 years as kind of an arbitrary number. But, so much time and energy and inertia goes into making some of these things happen. It's hard to find the time and energy and inertia to really do it again. Yeah.
We'll go back to the web.
Does Cerner have an interest in the implementation of personal health records? If yes, please elaborate.
We have a lot of interest in the personal health record thought. And it's primarily, I mean, our focus has been so far in support of chronic disease management. There's a lot of information that patients living with chronic disease, there's a lot of value to them in terms of being able to have access to a personal health record where they can capture their own data, they can get access to other sources of information about their disease. They can get access to their GP, perhaps, or specialists. We believed in it enough that, I don't know how many years ago, don't hold me to this, but it might have been 5 years ago. There's a community called Winona, I think it's Winona, Minnesota, or Wisconsin, I can't recall. I've been there twice, but I can't recall. It's a small community of about 40,000 people, maybe a little bit less, where we thought, it's captive enough. It's a wired community. They invited us in and said, we like what you're doing in certain areas of automation and linkages. We'd like to trial the whole idea of being able to offer up to our patients the access to a personal health record online, being able to use that person. And they used it, to capture immunization, a number of stats. If a patient had diabetes, they kept a lot of their blood sugar recordings and things like that. But also we took it a step further and connected them with their GP so that they actually had a vehicle that they could communicate to one another, and the GP could monitor the readings that were being recorded. We went so far as to connect the retail pharmacy in the community. So the GP could actually prescribe online and have that carry through to the pharmacist who could actually dispense from that. It's been a great initiative, and really it was one that we invested in. It wasn't a revenue generator or anything like that. It's just that we believe that in the technology and the capabilities enough that let's go do it. We are looking for we have some other examples of that, and I expect that we'll continue to promote that capability.
The last question for the web?
I've been getting some more since.
Okay. Well, we'll maybe circle around to the audience.
Can you discuss the value of automated systems in the public health domain?
I'm not sure that I could. Could they elaborate on that? Automated systems in the public health domain.
I guess he's asking for
elaboration on what?
Elaboration, so
what this?
maybe they can send that while you go on to the next question.
What impact does the changes in personal privacy have on the opportunity for improving connectivity and your company's deliverables?
There's a constant struggle. Privacy and security has been to a certain extent an impediment at times to being able to roll out systems fast enough, quickly enough, effectively enough. But for all the right reasons. I mean, I don't deny it. Obviously, the information is sensitive information. It needs to be protected. We have implemented all sorts of tools to manage, I guess, the security of that information, the privacy of the information, to audit that information. It really starts to get prevalent when we get into some more initiatives where we actually are sharing the technology, sharing a service. So we may have started with one organization who's invested a lot. They've done good things with IT, and now they want to extend it out to some of the community hospitals in their area. And of course, it opens up questions about, well, who has the right to see out there and that sort of thing. And I think that by and large, we've done a really good job of being able to implement enough sophistication around who needs to see what and when, and do we have appropriate audit tools in place to go back and measure who actually had access to the record, what did they see, did they have a need to see, and really report on that and give the capability to say, do we have any breach or not. It's an area where we provide constant diligence to, and I think that we've done by and large a pretty good job of it.
Maybe while we're just waiting for things to catch up on the web, maybe you can tell us what do we need to do? What do colleges and universities need to do to address this need for skilled health informatics people or people that can address your HIT environment. How can we help with that? What do you guys need in terms of industry?
Wow, that's a great question. And I'd like to turn it around and say, well, what do you need? I love, a vehicle like this to be able to actually get closer and talk. I've been invited into UVic a number of times, and we've had some good dialogue there. We are trying hard to extend our capabilities, especially where we're working with large centers, large academic centers, to open up the tools that we have and offer it up to the local universities and actually make that part of their curriculum. Haven't been very successful in Canada yet, not because there isn't a desire to or perceived value to do that. It's more about capacity and cost and people to manage it and that sort of thing. So it's definitely a two-way street, Shirley.
Does your organization have students as part of their take on students during their undergraduate degree, or?
We do some of that, probably not enough. Yeah, but we're definitely interested in that sort of offering. Yeah.
Any other questions? Yes, back there.
Is it on?
Yes, it is.
Yeah. First, I'd like to thank you for this nice presentation about your successful experience at Cerner and the challenges that someone might face in the area. Actually, I have a question with two simple folds. My first question, you mentioned in the presentation about providing enterprise solutions whereby you can communicate patients or persons in two different geographical locations. So I'm just interested to know what kind of underlying infrastructure do you actually use to actually do this kind of communication? Do you use a simple internet, or you have your own private networks to actually achieve that? And the second fold actually is at the end of presentation, you mentioned that the current challenges include something like delivering real-time services and real-time streaming where you have a patient or doctors communicating real time. So what kind of approaches are you willing to take to actually achieve, especially that currently internet, if you plan to use internet, it's not that reliable to actually have this kind of delivery. Thank you.
I'm not sure that I'll be able to answer that question to the extent that you would like me to, or that I would like to. As I mentioned, we offer up a number of vehicles, access vehicles through thick client, thin client, internet connections, VPN connections, using all industry standard technologies. We also have our own. We've developed this is sort of a new emerging need for me, where we have. I'll give you an example. We've done a lot of work down the road here with London Health Sciences and St. Joe's Hospital and the surrounding hospitals in the Thames Valley. They're all sharing a single instance of a system like this. Further north, up in Owen Sound, Grey Bruce Health Services is doing a very similar thing. And they have a number of organizations, Grey Bruce Health Services, South Bruce Grey, and Hanover, all share a single instance of Cerner, and there's only there's a one person, one health record thought. There's a referral pattern, usually from the north to the south, where Grey Bruce will send the patients down to London oftentimes for treatment, but there's no mechanism for them to look into one another's record. By virtue of the work we've been doing in the UK, and I think at University of Pittsburgh and some other areas where we have two large instances of Cerner, we've created the capability to be able to look into one another's database or health record with the appropriate security and privacy restrictions in place. We haven't implemented it yet here in Southwest Ontario. We're anxious to do it. The capability exists. We just have to get each of the two systems to a common level or a release level. And as soon as we're done that, we've agreed that we're going to do that. That's, to me, it will make great strides. They don't need to send them down with all of those paper charts and all that sort of thing. They can actually look into one another's records without ever moving. I'm sorry, the second question was what level of services? I'm sorry, I missed it again. What level of? Oh, real time. Yeah. Yeah, other than, what I mentioned, we do have internet connection where appropriate.
So you use internet basically?
Yep.
What about reliability?
Internet is really, we use it as a passive, as a lookup. We don't use it in any other kind of interaction.
Question back here. We'll take two more questions, one here and one there.
Hi.
Hi.
Cerner has implemented a lot of systems across the world. Just wondering, what are some of the practices you do deal with the historical data or migration, system and migration?
Yeah, that's a great question because we have worked with clients who've already, they're on their second or third generation of technology by the time they come to us, and they've already got quite a bit of historical data. And that's the first thing we do before we start the project is work out how much of that data they want to bring over to the new system. And generally, we try to bring as much of it live before they actually go live. So we have tools and processes and people who can help them with that. It's somewhat routine for all of our implementations.
And Frank?
A lot of health and medical data is in natural language. What are some good examples of the ability to deal intelligently with text data or other such things rather than discrete data or quantized data?
We have our own, internally we have our own controlled medical vocabulary to be able to interact between various coding systems, what one coding system means to another and things like that. Everything we do when we work with clients on our implementation, we stress over and over again, we want to codify absolutely as much information as we can. If we have to store blobs of data, then we have to. But by and large, there isn't very much left that isn't codified in the systems that we employ.
Just one more question for you. Many people come up with some really great solutions within universities. A lot of systems are prototyped. There's a lot of descriptions of interesting software all over the literature. Many of us would be able to develop even better solutions if we had a chance to try it out on systems like yours, if we had kind of a sandbox to play in, even if we're not affiliated with a teaching hospital like Waterloo is in. Do you do anything like give an implementation of your software, at least at some kind of level, to universities to be able to develop plugins on some kind of open source platform? I know AGFA does similar things with their new Impacts system.
To my knowledge, I don't think we have. I think most of the work that we've done with universities has been more at the, not at the engineering level, but more at the caregiver level. So we work with a number who have a nursing program, for example, or some of the other med schools, some of the other disciplines. We encourage them to use in fact, we've actually set up in our data center the capability. We have a test domain whereby they can actually use our order management system and things like that as part of their curriculum, and we'll help them refresh the data from one course to another, that sort of thing. But I love your idea of a sandbox. I mean, we have 2,000 engineers who, from my perspective, live in a sandbox every day. But if we could make that a virtual sandbox, that's a pretty interesting thought.
Is your question quick? Do we have... Okay.
You mentioned the emphasis on home care and bringing the care and the connection to patients further away from the hospital and maybe closer to their home and where they are. So Google Health, I log in maybe once a month, and I see third-party support for growing every month. I don't know if it's more of a U.S. phenomenon, but how does that complement or challenge maybe what Cerner and others are doing in that area?
The work that
With respect to a personal health record, where you're able to see or input for yourself your own histories medically.
Well, if that can just be another source of reliable information, then that would just be another source of data, I guess, for our clinicians. I don't see it anything any more than that at the moment. It's just another source of personal health record information if it's validated and trustworthy and so on, and clinicians want to use it and gain access through our capabilities, then yeah, so be it. Yeah. I fear I didn't mention, sorry, just to go back for a second, when we talked about codifying the information, obviously, I mean, we respect, ICD-10 and all of the other standard nomenclatures out there, and we make that part of our data capture and so on. It's not all Cerner specific codifying. Just want to make that clear.
I'm afraid we've run out of time, and I know that there's still probably more questions that the audience would like to ask. And so maybe we can forward those questions to you if there are some on the web that we didn't get a chance to address. And I apologize to our web viewers about that, and to the audience too, because I feel that there are more questions that you'd like to ask too. But I want to thank you so much for coming here today. It's been my pleasure to have you speak to us and just to have you here for the day. So I have a small token of our appreciation. So thank you. I hope you come back to our campus again. And I'd also like to welcome each and every one of you in the audience, and particularly the students, to stay. Hopefully we've still got some refreshments that you can enjoy while you meet and network together. I don't know from where all the students came from, but I know that there are a number in the audience, and it might be just a chance for you to meet and talk and get to network a little bit. So please stay behind and enjoy the refreshments, and please come back in September 24th, to hear Brant Myers from Cisco. So have a great summer, and see you in September.
Thank you.